This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Derek Stitt from Mayo Clinic. In this Neurology podcast, I'm delighted to be joined by David Plante to talk about his January Green Journal article, Prevalence and Course of Idiopathic Hypersomnia in the Wisconsin Sleep Cohort Study. David is my Midwest neighbor. He's the director of the Wisconsin Institute for Sleep at UW-Madison. I think David and his team did a really nice job on this paper on shedding some light on a disorder of sleepiness that, as we'll talk about, may be under-recognized and certainly is not yet fully understood. David, we really appreciate you coming on today.
Derek, it's a pleasure to be here. Thank you for having me.
So when it comes to idiopathic hypersomnolence, I think it's best if we start with some background, especially considering it has previously been felt to be comparably uncommon to other disorders of hypersomnolence. So I was hoping you could begin by helping us review the essential features of the clinical history and testing for the diagnosis, especially compared to more well-known entities like narcolepsy.
The best way to think about it is idiopathic hypersomnia is considered to be a central nervous system disorder of hypersomnolence, so like narcolepsy, but it typically presents a bit differently from narcolepsy. So both disorders are characterized by excessive daytime sleepiness. So people have either difficulty staying awake during the day or may experience severe drowsiness. There are, however, some important differences between the two disorders. So patients with idiopathic hypersomnia should not experience cataplexy. So cataplexy being the loss of muscle tone in response to emotional stimuli, sort of classically laughter or mirth is what the textbooks will say. But cataplexy can actually be a highly specific symptom of narcolepsy. Additionally, there are some other differences in how patients with idiopathic hypersomnia sort of experience their symptoms compared to folks with narcolepsy. So classically, in idiopathic hypersomnia, it's common for people to have non-restorative sleep, often with prolonged sleep episodes, as well as severe sleep inertia, during which it's very hard for people to wake up from sleep or become fully awake. So as a result, patients with idiopathic hypersomnia, for example, will often set multiple alarms, and they'll often avoid napping because they often feel worse after a brief nap, which is a little bit different from how patients with narcolepsy may classically experience their symptoms, where they'll often find a brief nap to be refreshing and help them manage their symptoms, albeit for maybe a brief time. So in terms of the workup of both narcolepsy and idiopathic hypersomnia, first thing you're always trying to do is rule out other disorders or comorbidities that might be contributing to the symptoms of daytime sleepiness, because daytime sleepiness is really common in the general population. Probably 25 to 30% of people in the general population will experience excessive sleepiness. That's where the practice of sleep medicine sort of becomes involved in trying to figure out if people have idiopathic hypersomnia or not. And the standard practice is to get a couple of sleep tests. So one is called polysomnography or an overnight sleep study. And that's followed by a less used test called the multiple sleep latency test, or MSLT. And the overnight sleep study is really important because it helps us rule out various pathologies that may be contributing to or causing sleepiness, like obstructive sleep apnea. And then the daytime multiple sleep latency test helps us quantify and measure the severity of excessive daytime sleepiness that people have objectively. During the MSLT, what happens is people have multiple repeated nap opportunities, 4 to 5 across the course of the day, usually spaced about 2 hours apart. And what we're measuring is how quickly people fall asleep when given the opportunity to do so, and if they go into REM sleep within 15 minutes of falling asleep, something we call a sleep onset REM period. And then under our current diagnostic criteria that we use in sleep medicine, patients who have both idiopathic hypersomnia and narcolepsy typically fall asleep relatively quickly, on average under 8 minutes. But there's a difference in sleep onset REM periods, where patients with narcolepsy typically have these sleep onset REM periods, either on their overnight sleep study and or during the nap testing that's done on the MSLT, whereas people with idiopathic hypersomnia, you don't see these multiple sleep onset REM periods on the sequence of tests. And there's a few other differences between idiopathic hypersomnia and narcolepsy that I think are important in terms of both their pathophysiology and their workup. We actually really know quite a bit about the pathophysiology of type 1 narcolepsy, which we used to call narcolepsy with cataplexy. We know that this is fundamentally a disorder that results from the loss of orexin-producing neurons in the lateral hypothalamus. And orexin is also called hypocretin. Sometimes people get these things confused or think there's a difference, but they're actually the exact same neuropeptide. And we presume in type 1 narcolepsy that this is an autoimmune phenomenon, and that's based on several levels of evidence that we have. And so actually it turns out as an alternative to doing a sleep study and a multiple sleep latency test, you can make a diagnosis of type 1 narcolepsy by doing a lumbar puncture and directly measuring CSF orexin. And if it's low, that actually confirms the diagnosis of narcolepsy. But if you were to do such thing in someone you thought had idiopathic hypersomnia, you would likely find that their orexin level is totally normal. And so really, in short, we know quite a bit about narcolepsy and what's causing it, but we really don't know much at all about idiopathic hypersomnia, which remains sort of a quintessential disorder of unexplained daytime sleepiness.
Thanks so much. That was a really helpful background. What were you and your group seeing in your clinical practice or your academic work that inspired you or prompted you to do this study?
I'm a clinician scientist, and I take care of patients with these disorders. And I spend a lot of time seeing patients in my practice who have excessive daytime sleepiness. And that's the bulk of my clinical work. And sort of in the scope of my clinical practice, I've cared for a number of patients with idiopathic hypersomnia over the years. I have a number in my practice, but then also I've met patients who aren't even maybe directly under my patient care who have idiopathic hypersomnia in our clinic, because I'm not the only provider who sees these patients. And, I recognize that I have a very specific research interest in central nervous system disorders of hypersomnolence. But it's always seemed to me really that there are an awful lot of patients with idiopathic hypersomnia floating both in our clinic and then also in other clinics that I've worked in, both as a trainee and sort of at other places that I've visited. So I've always kind of had the suspicion, well, maybe this is more common than we generally have assumed. And then another sort of data point that I have is that even outside of my work, I've met with people and talked to them about what I do. And they've mentioned to me that they have daytime sleepiness. And they actually ended up getting sort of a sequence of evaluations. People thought, oh, maybe it's going to be sleep apnea or something like that, but it turned out it wasn't, and they were diagnosed with idiopathic hypersomnia. So I know that it can and does exist and occur based on my life, both outside of the clinic and inside of the clinic. And so the real question was like, how common is this problem? So really think that that's sort of what drove the research and sort of led us to sort of do this particular study using the data from the Wisconsin Sleep Cohort.
I'd certainly love to know the why behind our guest's work. It's one of my favorite parts about this job. And so next, I was hoping that you could briefly introduce us to the Wisconsin Sleep Cohort. Tell us what's special about it, because it does seem to be like a special entity, I think. And as succinctly as possible, I know it might be tough, kind of review how you use the cohort to really get a truer sense of the prevalence of idiopathic hypersomnia.
Yeah, so I'll start by talking about the Wisconsin Sleep Cohort, which you're right, is an incredible study. It's a really important epidemiologic study in sleep medicine. It started back in the late 1980s, and it was originally designed to try to estimate, one, the prevalence of obstructive sleep apnea, because at that time we really didn't know how common it was, and then also its impact on health. So the study itself was pretty interesting in that it used a sampling frame of Wisconsin state employees, and that allowed for basically a stratified random sample of working persons across a range of various demographics, so ages, educational levels, etc. And basically they followed people longitudinally since the late 1980s until now, oftentimes with serial sleep studies or polysomnograms in the sleep lab every 4 years or so. And then they've also had a whole host of other objective measures that have been taken, subjective measures. A wealth of data on these people has been collected over time. So it's a really, really rich data set that allows us to understand sleep health sort of broadly described. Over the years, it's grown in its scope. So it told us a lot about the importance of sleep apnea and general health, but then it continued to grow and look at other sleep disorders as well. And so it's given us this very unique opportunity to explore idiopathic hypersomnia. And that's because one of the things that was done in the cohort study for a period of years was the collection of multiple sleep latency tests. So not only did people have overnight sleep studies to see if they had sleep apnea, and if so, how severe it was, but they also had, for a period of time, multiple sleep latency tests during the day, where they actually quantified how sleepy people were using a subjective measure, if people went REM sleep early. which is very unique. To my knowledge, there's really no other population-based data set that has this number of multiple sleep latency tests in it, which is really, really important because you need that information right now to make the diagnosis of idiopathic hypersomnia. And also what's really important about the cohort study in general, and its use in this way, is it allows us to look at the prevalence of idiopathic hypersomnia in this cohort study that is not biased, because historically the way that we've estimated how common idiopathic hypersomnia is by looking at people who come into sleep clinics and who ultimately get diagnosed with the disorder or the condition, and then compare it to the other folks who've come into clinic to seek evaluation. So that's already sort of a biased sample, right? It's hard to estimate what the prevalence is in the population there. The other option is to look at insurance claims data. That gives us maybe a little bit less biased picture because in theory it captures a larger sample, not just people presenting to sleep clinic, but also broader healthcare entity. But that also has some problems because you are biased. People may not be part of that because they don't have insurance. And also you're relying on ICD codes to decide if people have a condition or not. And as you're probably familiar with as a clinician, ICD codes can be really challenging to say that someone has or does not have a specific condition. So the sleep cohort study gave us this unique opportunity to use this very well-characterized group of individuals from a general population who had a wealth of very specific sleep data as well as other health information to really try to estimate the prevalence of idiopathic hypersomnia. So the way that we went about this was we took all the available persons who met some basic criteria, sort of having data to look at for the most part. And we were able to start to winnow down based on various diagnostic criteria, whether they could be possible or potential idiopathic hypersomnia cases. So first question would be, are you excessively sleepy? Do you report that you're sleepy we used the Epworth Sleepiness Scale, which is a very commonly used subjective measure in sleep medicine to get a sense of how sleepy someone is. And then we also looked at the multiple sleep latency test. Did you have a mean sleep latency below 8 minutes? If yes, you could move on. If no, then you wouldn't be considered a possible case. Did you have multiple sleep onset REM periods? If so, you would be excluded, from the pool. And we kept winnowing down further and further. We could eliminate sleep apnea. We could eliminate shift work disorder, all of these other things that can contribute to or potentially be the cause of someone's excessive daytime sleepiness. And then we were left with a pool of what we called probable IH cases based on looking at all the data that we had available to us to determine the prevalence of idiopathic hypersomnia.
You also used the cohort to do something else novel, and that's take an unprecedented and objective look into the natural history of idiopathic hypersomnia. And so I was hoping you could set the stage and tell us about the longitudinal parameters you looked at for that and over what time period it extended.
So that's another really powerful thing about the Wisconsin Sleep Cohort study is the fact that not only does it have cross-sectional data, which is what we use to establish the diagnosis of whether someone would be a probable idiopathic hypersomnia case or not, but it also had this longitudinal data that again spans for many, many years amongst its participants. And they've had relatively good participation over the years. A number of these folks have stayed in the study for long periods of time and are still in the study even. So what we're able to do, look at the probable IH cases we identified, and then look both retrospectively and prospectively from that time point when they had their MSLT, and look at their symptoms. And the main symptom that we looked at was whether they reported feeling subjectively sleepy, again, their Epworth scores, because we had that over a much longer period than multiple sleep latency scores. Although we did look at those as well, because a few participants had repeated multiple sleep latency tests. But we were able to look, and on average of the folks who we had data on, we had about 12 years on average worth of data to look in different directions at the course of their sleepiness, which is really quite astounding. I mean, being able to follow even my own patients for 12 years is sometimes a lot, right? So to be able to follow someone in a naturalistic study to see what the course of their symptoms might be over that span of time is really quite powerful. So that was another big strength, I think, of the particular research study that we're able to do.
That's great. That's awesome. So let's get into the most noteworthy things that you learned. Start us off and tell us what you found regarding the prevalence of idiopathic hypersomnia, and was it a surprise?
We had about 792 participants who met our basic available data for analysis. And among those, we found 12 probable idiopathic hypersomnia cases. So that equates to a prevalence of about 1.5% So this was surprising to a degree. Okay, so it's still not a super common disorder, but it's not uncommon at all, at least according to these estimates. Because if you look at the previous literature, again, that kind of comes from these biased data sets, our estimate of 1.5% is probably somewhere between 10 to 100-fold more common than previous estimates, or more, really depending on the study that you're looking at. And what's really, I think, important about this estimate, again, coming from we think a less biased data set, is that it puts the prevalence of idiopathic hypersomnia on par with some very common psychiatric and neurologic conditions, things like schizophrenia and bipolar disorder, Parkinson's disease, epilepsy, those kinds of things. So it's probably pretty common, which again, maybe wasn't a surprise to me and maybe some other folks who practice in this area or in sleep medicine, but I think it is kind of surprising based on the previous literature.
Certainly, that's remarkable, especially when you compare it to the prevalence of some of those other more widely known conditions you mentioned. And now on to the longitudinal data. So tell us what you found regarding the clinical course of idiopathic hypersomnia when you looked at these patients over time.
When we looked at these participants, again, they were in the naturalistic setting. We weren't doing anything to them. We had longitudinal data on 10 of the 12 participants that we identified as probable IH cases. And of those 10 participants, we had an average of 12 years of data. So it's a little bit different from person to person, depending on, if they dropped out or returned or not, or if we were missing a data point. But on average, again, quite a bit of time. And what we found that the course of daytime sleepiness for the majority of these folks was chronic. So most of them continue to have elevated Epworth Sleepiness Scale scores. They remain sleepy for most of the time. However, in about 40% of these individuals, their Epworth Sleepiness Scale actually dropped. And we weren't always able to identify why this might be happening. In looking through their charts, we could identify potential causes for improvement in symptoms, starting a medication, increasing caffeine intake, those kinds of things. One was we couldn't find any reason that we could identify, but suggests that people's symptoms can get better. And that I think is really, really important because there's general sense among many people in the sleep medicine community that if you have idiopathic hypersomnia, it is a lifetime diagnosis and people cannot get better. I think that these data support some data from both case series and case studies, as well as one controlled data set that came from a sleep clinic, that folks who meet criteria for idiopathic hypersomnia can actually get better over time, and a not insignificant number of them can. And I think that's really helpful in helping us both understand that there may be treatments that can improve things for people, there may be spontaneous remission, but also gives hope to patients and letting them know that there's a possibility that they will improve over time.
Thanks for that. I thought it was great to see that there's objective evidence that there's a substantial, sizable minority of patients that can have improvement. But yeah, it does seem like it is a chronic, more long-haul condition, as you had thought, but maybe with some silver lining there. One of the things I also want to mention that I was impressed with is how in the paper, you rightfully discussed some potential limitations of the study, some possible means for misclassification of patients as having idiopathic hypersomnia. However, I think you did a really nice job, you and your team, of divulging why these possible confounders likely did not have a significant impact on results. And I was hoping you could elaborate on that a little bit.
There's always potential limitations to any study that you do. And I think in this case, really, there's a trade-off. It's a double-edged sword to use a population-based data set to try to make a diagnosis of idiopathic hypersomnia because you have to rely on the data that's in front of you. You can't go collect more data. I mean, you could at future time points from these folks, but you can't call them retrospectively and try to understand what's going on. And also, unlike being in the clinic, you can't directly manipulate the conditions or the things that the patient may be experiencing to test hypotheses about what might be causing their sleepiness. So a great example might be if I had a patient who was in clinic and maybe they met criteria for idiopathic hypersomnia after some testing, but I had a suspicion that maybe they were a habitual long sleeper. So these are people who they need more sleep than other folks to feel refreshed, maybe 9 or more hours. But if they got that they would feel a lot better. That shouldn't be idiopathic hypersomnia. And what I might do is I might do a control trial saying, well, let's do some sleep extension in you for a period of time and see if you actually feel better. And if you do, that might change the diagnosis. We couldn't do something like that in the cohort study. Similarly, a big challenge is around periodic limb movements of sleep. These are things that we see very commonly on sleep studies, especially as we get older. It's often not clear if they really have significant clinical importance outside of their relationship with restless leg syndrome. We know that about 80% of people with restless leg syndrome have significant periodic limits of sleep, But the vast majority of people who have periodic limb movements of sleep don't have significant restless leg syndrome. And it's not clear if it's just an incidental finding that really is driving symptoms. But in a clinical setting, I might try a dopamine agonist, for example, to see if that empirically improves their symptoms during the day of daytime sleepiness, because I know those can be highly effective at treating periodic limb movement disorder. So you can't do those kinds of things here. So we just kind of have to live with a little bit of ambiguity around the diagnosis. But I think we did as good of a job as we could with the data that we had, which was quite rich. And I think that most people, if they were sleep clinicians, looking at sort of the data set and how we did this, would agree that these folks would generally meet criteria for idiopathic hypersomnia.
So let's finish with this. Based on your findings in this study, I was hoping you could give us 1 or 2 points that the listening general neurologists should glean from this project to maybe use in their practice when they see a patient with hypersomnolence, which is, even for the general neurologist, probably a fairly commonly encountered complaint, whether or not it be the primary reason they're seeing the patient or secondarily on a review of systems.
First, it's important to realize that there's a whole host of different disorders that can cause daytime sleepiness. And so it's really important to try to do a workup to get to the bottom of what might be causing the symptoms so you can direct management to that problem. But I think that maybe the take-home point from this study is the idea that people may have a diagnosis of idiopathic hypersomnia, this unexplained hypersomnolence, when you get to the end of that workup. People with idiopathic hypersomnia probably aren't zebras, right? They're probably more common than we might think. And so I wouldn't be surprised if you have people with idiopathic hypersomnia, both in your clinic and then also in your life as well. So it's always good to keep it in the back of your mind, but it is still a diagnosis of exclusion. But I don't think it's as uncommon as we have thought of it historically. And the other thing that I would mention is that it's important in clinical practice when we see patients with idiopathic hypersomnia, even if you're not, that's what you're not treating necessarily, right? As a neurologist, you may be managing some other co-occurring condition. I think it's important to remember that it's a treatable condition. There are now FDA-approved medications to treat this disorder. There are more being studied, and people also can get better. We see that in this particular study. It's really important for patient care to recognize that and educate patients appropriately and correctly around that. In one sense, to provide some hope for folks that they can get better, because a lot of these folks really are struggling with the condition. So I think it's good to give them hope that they can get better.
Great points. David, we really appreciate you sharing your expertise today. Thanks for coming on.
Well, I really appreciate the opportunity, and thank you so much for having me.
Well, that's all for today. Be sure to go check out David's article already published in the Green Journal in January. I'm Derek Stitt for the Neurology Podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.